he'll be speaking about case-based lipid management, selecting treatment, and managing side effects. Mike?
Thank you, Kristin. Thank you for having me. I always enjoy this. Oop. Case 1. So we have a 67-year-old individual on Social Security income only with an ST elevation anterior MI with a primary stent to the LAD. Just for John, we made this a non-drug-eluting stent. Okay. She has also residual coronary artery disease with 50% in the RCA, 50% in the circumflex, a relatively low ejection fraction immediately after his MI. Baseline LDL was actually pretty low, 127. Not uncommon, by the way. The average LDL now with an MI is right around the 125 range. Okay. HDL was 35 milligrams per deciliter, triglycerides 210, also not, unfortunately, uncommon numbers. No history of diabetes, but a fasting glucose on the day after the event, the only one taken was 143 milligrams per deciliter. His BMI is 29 with a waist circumference of 42 inches. He had no additional labs drawn. He was discharged home on day 3. The best initial treatment is which of these for this specific patient? Atorvastatin 80, simvastatin 80, simvastatin 40, pravastatin 40, rosuvastatin 20. Each of these is an evidence-based dose for various different types of trials that have been done. The answer actually is the 80 milligrams of atorvastatin, as this was the dose used in the seminal trial called PROVE-IT, where 80 milligrams of atorvastatin was compared with 40 milligrams of pravastatin in individuals immediately after their MI. There was a 16% relative reduction in a combined endpoint of death, MI, stroke, and revascularization. Half of the endpoints were hard endpoints, and half of the endpoints were the softer revascularization endpoints. Okay, so it's a pretty good trial, as there are a fair number of endpoints. The relative risk reduction you see there. I'll mention a couple of key things about the trial as we continue to talk about it, but this is the evidence-based medication to use in this situation. The question is it the only medication you use, and is evidence really need to be used here in everybody? So, as I stated, the original medications that I talked about in the list that I gave you actually are all associated with outcomes in various trials. The simvastatin 80 milligrams in A to Z, another acute trial that was done that was actually neutral for the overall trial, but if you look from 6 months to 30 months, which is where the trial ended, there was actually a big benefit in the last 6 months, or last 24 months of the trial. In the first 6 months, no difference at all. Whereas in PROVE-IT, as you saw with this, there was almost immediate divergence of the two curves. The comparator in the simvastatin was simvastatin 20 rather than 80. Simvastatin 40 is a good long-term drug. We know that from the HPS trial, a very, very good trial that gave us a lot of data about statins. Pravastatin 40, one of the original trials done in CARE, very effective drug. And then rosuvastatin, the most recent trial, very effective in primary prevention, not secondary prevention. But if it works to prevent a first heart attack, it'll probably work to prevent a subsequent heart attack. So all of these are evidence-based medications. And again, the, quote, applying the true evidence would be atorvastatin because it really fits with this patient. The problem is some of the things do and don't fit with this patient. I'm going to talk a little bit more about the evidence and a little bit more about what doesn't fit with this patient. First, what the evidence is really showing, if you kind of move it around a little bit, is that the lower the LDL is, the better you do, and each subsequent trial, as has been shown in this, shows that the lower you go on the LDL, the lower the event rate is. And when you do a plot of this, what you see is that the ideal LDL seems to be somewhere around 40. Okay? The various trials are shown there. The LDL basis that we have right now is right around 70, and both PROVE-IT and then TNT, which was a long-term trial, got down there. PROVE-IT actually got their patients down right around 60 as a goal. So somewhere between 60 and 70 is a very reasonable number, an evidence-based number, but it is reasonable to use a number rather than just a dose. based on this type of analysis. Okay? The other big issue is cost. Okay? And right now, unfortunately, atorvastatin is not a generic medication. So it costs somewhere between $50 and $150, so I made it an average of $100 for the individual to buy. If you have to buy it off the shelf, it's at least $150. If you have to buy it through your pharmacy, it's often the high tier, third tier, which is $50. Okay? And a lot of people don't like that compared to the cost of, say, pravastatin, which is $4 a month. And if you're on a fixed income like this gentleman is, Social Security only, that's a huge chunk of your income to have to pay. On top of the other medications, Plavix, a beta blocker, an ACE inhibitor, and perhaps other more expensive medications if they're diabetic. Okay? He isn't yet, but he's moving that way. Okay? Simvastatin 80 is generic and flat priced. It's the same as Simvastatin 40. Pravastatin is a $4 drug at one of the very large, to be unnamed stores. This is a big box. And all the other big box stores. And then rosuvastatin, unfortunately, is also not generic, but has very good outcomes associated with it. Okay? So, and if you look further at evidence, the goals aren't based on what the evidence is, which is a fixed dose treatment, but the goals are based on numbers. Rightly so, because if you're going to get people to follow goals, you have to make an algorithm that is easy to understand, and you have to make an algorithm that's easy to remember. And the algorithm we have for NCP is easy. 160, 130, 170. And what's shown here is the 170. Okay? Just a part of this. Okay? This individual's baseline LDL was 127. Okay? The percent LDL reduction needed to achieve goal is 45%. Okay? 21% to reach a goal of 100. All right? So how much statin is that? Well, you can basically use this kind of comparator to figure that out. And the way to figure it out and the way to remember it is 80 of fluvastatin, 40 of lovastatin, 40 of pravastatin, 20 of simvastatin, 10 of atorva, and 5 of resuva, give or take a little bit, essentially are equivalent and cause 33% reduction. This is what I teach to our interns, because even an intern can do 1/3 of some number in their head most of the time. Most of the time. Yeah, with the hours now and everything else, they have to be able to do those kinds of things, but that's okay. All right? So, then every time you double a statin, it's 6% more lowering. So if you went from 20 of simvastatin to 40 of simvastatin, you will go from 33% lowering to 40% lowering. Okay? If you went from 40 of lovastatin to 20 of lovastatin, you get 6% less, which is 27%. So for our patient, shown in the green lines here, okay, for the LDL goal of 100, you could use somewhere between around 40 milligrams of simvastatin, 20 milligrams of atorvastatin, or around 5 to 10 of rosuvastatin. Okay? For the 100 milligram goal in our patient, you could use 40 of fluvastatin, 10 to 20 of lovastatin, 10 to 20 of pravastatin, 5 of simvastatin, and you just kind of sniff the atorvastatin and rosuvastatin bottles. Okay? Is all you would need to do. But that becomes important if you're trying to get people to goal and or you have to use various sundry different types of dosing mechanisms to get them to actually take it because of sensitivity. Okay? But so it's relatively easy to figure out where the drugs come, how you can get to goal. It's extremely predictable in most patients.
So now let me clarify. You would argue to use the evidence-based dose as a first, or you would start with a targeted goal?
I would argue that the patient needs to be on a statin.
Right.
And I would make sure I ask the patient if he can afford that statin for at least a while.
Okay.
And if he can afford it for at least a while, then I would start with the evidence-based statin at that dose. Okay. If not, then I would give him a generic statin that would get him to
try to get him to goal.
Try and get him to the most aggressive goal possible, again, within reasons of safety and the medication he could take.
So it's a hierarchy.
So it's a hierarchy. I always try and use the evidence-based dose first, make sure they can afford it, because what happens if you don't ask the question is they won't give you the answer, which means they won't take the drug. Because they'll go home, they'll say, I eat, I have my house, I pay my air conditioning bill with it being 100 now in Durham today, okay, or I take my statin. That's an easy call. I'm going to pay my air conditioning bill and I don't need the pill, okay? And so ask the question, you'll get the answer that you need, and then you can be flexible with your answer. That's why I present it this way. Now, the other thing you always need to take into account when you're picking these drugs is how safe is it, okay? And this is a very nice article done by Dr. Cannon from Harvard, looking at the various kinds of risks for rhabdomyolysis, which is the worst risk, CK elevation, which is just an indicator of some muscle injury, okay, and liver dysfunction between 4 trials that were done recently comparing various statins. In the Prove It trial, which used atorvastatin, is at the top. A to Z, which used simvastatin, is the next. TNT, which used 2 different doses of atorvastatin, is next. And then Ideal, which used simvastatin versus atorvastatin, is after that. Okay? And what you basically see is that in all cases, you're really not looking at very much risk, because the absolute risks here are all in the points. So you're looking at ones in thousands to maybe 1 in 100 at most. So the risk for very bad events is very low. How do you describe these events to your patients? Statins irritate the liver, they don't damage it, okay? No person on a statin has ever had hepatic failure alone from the statin, okay? So statins just don't cause hepatic failure. They'll irritate it, stop the statin, it goes away. The number of patients that will come into your office saying they won't take a statin because it's going to kill their liver is somewhere between 5 and 10 and 100. Because of that great information highway called the internet, where they read that that's what's going to kill them. So that instead they can take their red yeast rice or something else that they're buying that really is rice with red food coloring on it that really doesn't work very well. Okay. Red yeast rice, if you get it from the right place, actually works quite well. But most red yeast rice off the internet is rice with red food coloring in it. Okay. All right. So it doesn't harm the liver. It irritates it, stop it, it goes away. Muscles it can harm. But the muscle risk is really low, it is dose-related, and it is in a real hierarchy. Simvastatin being the most myopathic of all the statins, okay? And then after that, all of the other statins are pretty much very low risk. And interestingly enough, one statin has never had rhabdo associated with it, and that's fluvastatin, okay? So you really have simvastatin at the top, all the other statins more or less in the middle, and fluvastatin at the bottom with regards to myopathic risk, okay? And that goes for both rhabdomyolysis and CK elevations. Okay? And those other statins are really, really safe. Simvastatin at 80 milligrams, you're looking at a rhabdomyolysis risk of about 4 or 5 in 1,000, which is pretty high. Okay? It also interacts with a whole lot of drugs, so you can increase that risk dramatically by eating a grapefruit. Okay? You can increase that risk by taking Biaxin. Okay? You can increase that risk by taking amiodarone. Because it interacts and because you've really reached the ability of the liver in most people to metabolize that drug, you're sitting right on the edge of having a problem. That is not the case with the other statins. They all do quite well, and they have lower risk for that reason.
And now you mentioned the grapefruit, and you know, if there's one thing I get asked about in clinic all the time, and my family who's on statins asks is, you know, I can't have grapefruit juice, or I can't have a grapefruit because I'm on a statin. So is it really one grapefruit, or
if you were on simvastatin 80, I wouldn't take more than a grapefruit for sure. Yeah. Okay, because I'd be a little bit worried about that with the other drug interactions and the amount, depending how big you are. So if you're really slight, that's a big issue too. With the other ones, let's see, for rosuvastatin and atorvastatin, it'd probably be about 4 gallons. Okay, a day.
4 gallons of grapefruit juice.
A day.
Yeah, a day.
So okay. you really don't have to worry much about that risk. Okay, if you're drinking 4 gallons of grapefruit juice, there are other risks you have to worry about. Yep. Okay. All right. Okay. What exactly can you expect for the incidence, and is the incidence associated with the LDL level? So the answer is that you can expect the incidence in someone who takes the drug to have a myalgia of about somewhere between 5 and 10%. So 5 to 10% of all patients who get placed on these drugs are going to have complaint of myalgia. Okay. Here, taken from Prove It, you can see that the incidence was 6.4%. It didn't matter what your LDL was. So it is not related to how low your LDL goes. It is simply related to being exposed to the statin. Okay? All right? The other thing is liver side effects are not related to how low your LDL goes. They are related to the dose of the statin. And the incidence there you can see was 2% or 2 out of 100. Okay?
Let me ask you one other side effect question. We often have patients come in who say they're thinking their cognition is not quite so good when we put them on a statin. Is there any evidence behind that? Is that a subjective, or is there objective data that support that, or a mechanism even?
There's no known mechanism for sure. There are theoretical mechanisms as to why this could happen. Ubiquinone, which is something that is inhibited when you give a statin from being made, is in great abundance in the brain. But there's actually no evidence that the statins actually get in the brain to stop that. Okay? Put me on 5 drugs, and I'm going to think a little funny coming out of the hospital after a heart attack anyway. So it's really hard to pull that apart. Okay? Extremely hard. The best way to figure it out is what I've done. I stop the statin and then restart it again and see if it comes back. The one thing I can tell you that does happen is simvastatin has been associated, because a little bit more lipophilic, may get across the blood-brain barrier a little bit better, has been associated with bad dreams. Not cognitive dysfunction, but bad dreams. So that is a known side effect of simvastatin. It happens about 1 in 1,000 to 1 in 10,000. Okay? And they're really bad dreams. Okay? You stop it, it goes away. You start it, it comes back again. But the other cognitive problems, you can have idiosyncratic reactions where people actually will be shown when you start and stop a statin to have that happen. But they're really idiosyncratic. They are not, you're going to have it in 1 in 10,000, 1 in 1,000. They're just one-off.
Yeah, never come up in the clinical trials.
No, it has not. And in fact, when they looked at preventing dementia, they looked at cognitive function, there was no change in the trials. Done both with high-dose statins in the atorvastatin 80 trials, and done with pravastatin as well in a trial called Prosper. Okay. Back to statins and muscle pain, it again occurs in about 5 to 10% of individuals. Many of the trials, it's difficult to tell. You have to be careful on how the trial was designed to get that number out, because a lot of trials have a run-in period of 6 weeks before they get randomized in the trial. If they have a run-in period, all of the side effects are lower because all of the people who couldn't tolerate it for 6 weeks dropped out. Okay? The 2 trials that did not have a run-in period were A to Z and Prove It, because they started right after they got in the hospital or out of the hospital. And for that reason, those are really good trials to look for side effect profiles. Okay? All right? This one study really looked at myopathy and myalgia. It's called the PRIMO study. It was done in France. Okay, 8,000 outpatients. It looked at individuals who took a high-dose statin within the last 3 months. Okay, and then what they did is selected 3 patients out of the last 2,500 or so, from 2,500 practice, the last 3 patients on high-dose statins who had a muscle problem, and then interviewed them and took extensive histories. And out of this study, they came up with some very good ideas on what happened. First, which statin is most likely to cause myalgia? Well, what they found is they used pravastatin as the incident statin, so that's 1. They found that fluvastatin was at 1/3 as less likely to cause myalgia, as was pravastatin. Atorvastatin about 1.28, and simvastatin 1.78. Unfortunately, rosuvastatin wasn't out, so we don't know the number with that drug. Okay? All right? So the most, again, you can look at pravastatin and atorvastatin being about the same, simvastatin being a little bit more myopathic, and fluvastatin, again, being the least. Okay? The other thing it showed is that how much symptom was pain, about 10% of the population. The median onset, 1 month after starting, so that's when it really starts to happen. Okay? Most common in the lower limbs. Okay? 25% of the time it wasn't muscle pain, but tendon pain. So if people complain of tendon pain or people complain of new onset cramps, think about the statin. Okay? All right? The symptoms were more common in people who were very active than in those who were very inactive. Activity is important and you don't want to limit them. Okay? 32% of the patients who had pain actually started limiting their activity because of the pain. 4% of patients actually became bedridden because of the pain. Kept taking their statin, because they were very nice, compliant patients. I was surprised this was done in France and not Germany. In Germany, it would have been 40%, right? Because they all follow directions. All right? Okay? But in France, even 4% of the patients actually got to the point where they were bedridden before they started to complain. Stop the statin and the symptoms go away. Okay? And I'll talk about how fast they do. What were the predictors? This is important to know. If you had muscle pain with another statin, odds ratio of 10 that you'll have muscle pain again. So it is a good predictor that's going to happen. History of unexplained cramps, odds ratio of 4, so more likely. History of CK elevation, not that correlated, only twice as likely, okay? If you've had no history for 3 months, the likelihood is very low. So if you've tolerated a statin for a while, it's probably not myalgia associated with the statin. And interestingly enough, if you got an antidepressant, you were less likely to complain, probably because if you had a little bit of baseline pain, you could tolerate it better and you didn't complain if you were on the antidepressant. That was how it was thought about. Probably no drug. How do you manage the muscle pain? Stop the statin. You can stop the statin for 6 weeks anytime you want with 0 risk, with one small caveat, and I'll tell about the caveat in a second. But otherwise, you can stop it for 6 weeks with no risk whatsoever. Don't ever worry about it, and then start them back up after that. Now, you really want to stop as long as it takes for the symptoms to go away, because you want to start at a new baseline, or for the symptoms to become baseline if they have chronic pain anyway. Okay? And then you want to re-challenge in one of 3 ways. The same dose if it was really atypical, okay? A lower dose if it was fairly typical but pretty benign, and if it was pretty life-altering, then I start with a low dose of another statin, okay? And I try and use a statin that is either going to be less myopathic, okay, or a statin that I can use a very, very low dose of, okay? So rosuvastatin 2.5, atorvastatin 5, which is half of the dose that comes for both of the lowest dose, or the other nice thing is fluvastatin 20. Now, 2 things about fluvastatin that are nice. 1, fluvastatin 20 comes in a capsule and not a pill. So you can get a lot of people who can't take the pill that will take the capsule. So, you know, if you can't dazzle them with brilliance, you baffle them with more brilliance. Yeah. Okay? All right? And then so that's the way I approach this, and that's the way it's commonly recommended. Now, when would I not stop a statin? I would not stop a statin before surgery. That's the only time I wouldn't stop it. Why? Because all of the data that's coming out of surgery now shows that perhaps a statin is going to be our best preoperative drug. It's a very interesting, very kind of early development field for the next kind of headway for what statins are helped for. But it looks like statins are very good at preventing perioperative MI by helping plaque stabilization, decrease in the inflammatory effect. So I wouldn't stop it in the peri-MI period, or peri-surgical period. Now, when you get muscle-related side effects, which is what MRSE stands for, okay, how can you treat them? Well, there's a study that was done by Dr. Stein and his partners. They took 200 patients, essentially, who had muscle pain before, and treated them with either ezetimibe, fluvastatin 80, or both, to see who could actually tolerate this or not. When they did that, the LDL changes are shown there, okay? The incidence of muscle-related side effects are shown, okay? And the incidence of individuals who couldn't take it is shown. So what I can say out of this is by using either ezetimibe, which I wouldn't use as a first-line drug, or fluvastatin, which I would, at a relatively higher dose, you can get about 95% of patients to actually take a medication who previously couldn't, okay? All right? You can get 30% reduction in LDL, which is significant, okay? And your goal for getting LDL reduction in somebody is around 1 millimole, which is 40 milligrams per deciliter. Okay? Now, if you do get myopathy, what is the outcome of your patient? They followed 45 patients who got myopathy. The mean onset time was 6 months, 9-month standard deviation, so there was a wide variation. Okay? Myopathy had a faster onset in individuals who had just come out of the hospital. The mean time of resolution of symptoms, 3 months. Okay? Everybody's symptoms resolved. So that's the key. Stop the statin, leave it off for a while, and everybody gets better. Now, interestingly enough, 37 of the 45 were re-challenged. Okay? 21 actually had recurrent symptoms. 16 actually were able to get on. So about 3/4, or about 60% of your patients will have recurrent symptoms. About 20% won't if you get as bad as myopathy. Now, the difference between myalgia and myopathy: myalgia, pain; myopathy, weakness. Best way to test myopathy: sit them in a chair, make them stand up without using their arms. They can't do that, they have myopathy without a doubt. They do it with struggling and could actually easily get up before, they've got myopathy. That's the best way to test myopathy. Okay? So that's how I approach individuals coming out of this hospital, looking at regards to cost issues, and then that's how I approach the most common side effect coming out of new statin starts: myopathy. Next case. So I have a 52-year-old woman who had an MI, okay? Anterior MI, no prior chest pain a year ago. 2 subsequent episodes of chest pain, 2 subsequent caths, okay, which she didn't like. Okay, she had a total mid-LAD taken to a minor irregularity with the first episode and a stent placed. She did jail a D1, which was probably what the cause of her second and third episodes of chest pain were. She had scattered diffuse lesions, okay, no family history, nothing else. And she blamed her problems on the fact that she didn't respond to a statin, okay? Her baseline LDL, which I didn't show here, but I do show here, was on 808, okay, with a baseline LDL of 102 when she came in. She was started on lovastatin 40 coming out of the hospital, okay, and on 1208 she had a repeat LDL drawn and it was 93, okay. The predicted fall with lovastatin would be 33%, which would be to about 70. So she actually got placed on a pseudo evidence-based medication. It is an evidence-based medication. It does have outcomes data. That's very good. It does get the patient to 70 theoretically, so it was a reasonable choice. It was $4, although this patient could afford more than that. Okay, and the actual fall, however, was only 9%. So she says, "Why do I not respond to tests? What kind of tests do I need, and what kind of medications would I do to try and work this up?" So typically, who doesn't respond to a statin? So patients 1 through 7 who come to your office who don't respond to a statin, don't take it. Okay? That's who doesn't respond to the statin most of the time. All right? Next is an individual whose baseline value was not accurate. So after an MI, your LDL will fall 20%. And if you wait until a couple of days after the MI to check what the LDL is, okay, what you're going to do is get a falsely low LDL. And that falsely low LDL you can't use as a baseline to predict what's going to happen with your LDL fall. Okay? This falls with any big illness, with any big surgery, and with a few big diseases, specifically and especially HIV and cancer. Okay? The other thing that can decrease your efficacy is taking the short-acting statins, which are fluvastatin, pravastatin, simvastatin, and lovastatin in the morning. That actually decreases efficacy about 6% compared to taking them at night. These drugs all go to the liver and actually are taken up completely by the liver and then don't go anywhere else. There's actually very little in the serum. If there's any that gets in the serum, that's what causes the myopathy actually in people. Okay? Because there's a huge first pass out of the liver. Block that first pass by giving drugs which block the metabolism of these drugs, you end up with rhabdomyolysis. Okay? Both rosuvastatin and atorvastatin have that same kind of first pass uptake, but they have very active metabolites, which then cause a prolonged effect of those drugs. And they'll last 24 hours, and you give them any time of day, it doesn't matter. They have the same effect whether you give them in the morning or at night. Okay? And then finally, the last one, which is actually the most common cause of not responding to a statin, is an LDL receptor defect. If you have a single defect, you don't respond quite as well as expected. If you have a dual defect, you will respond hardly at all. About a 10% reduction with a very high dose statin. Okay? The likelihood of having those two things is shown here. So what we did to try and figure out what was going on with this woman is we challenged her with 10 milligrams of rosuvastatin. And when we did that, her LDL fell to 77. Now, if you go through the logic, here's how it works. The estimated LDL response to rosuvastatin 10 is about 40%. Okay? So the rosuvastatin is about 10% more potent than lovastatin. 40. Back calculating, the baseline LDL should be 128, 77 over 0.6. Okay? The actual LDL response from baseline was only 24%. If the actual baseline LDL were 128, the response to lovastatin 40 would have been 27%, which is within the expected range of the usual efficacy. So essentially, if you use your rosuvastatin to back calculate to get your real baseline, then apply the lovastatin 40 that she got originally, you come to about where you expect, 28% rather than 33% lowering. She's not a non-responder. She is taking the drug. Okay? It's just that her baseline LDL was actually not where it should have been. And that's where it left. So she was very satisfied with that, very satisfied that she got her LDL down to 77 with the rosuvastatin, but she still wondered why she had so much disease when she came in as a healthy woman without much family history and what was going on. And the answer to that question was we checked an LP little a in her, and that was very high, extremely high. So usual for Caucasians is less than 5. Most of the time when you measure it, less than 25. Most of the time when you measure it, it's 1 to 5. Okay, it's actually rare to get it up at all. Okay, it's a little higher in African Americans. The exact function of this lipoprotein is unknown, but it's presumed to actually impair the work of plasminogen in the serum. And when it does that, what it does is it allows more thrombin to be deposited on your vessels than should be. When thrombin gets deposited on the vessel wall, it actually injures the wall and makes it much more permeable to lipids. So what it essentially is doing is, to me, the same thing diabetes does. Diabetes does not cause coronary disease. Diabetes predisposes you to getting it more easily. And this does the same thing. Okay? And to that end, what you need to do is to be much more aggressive with drugs in this patient population. So she really needs an LDL of about 50 rather than 77. So she needs dual therapy. She unfortunately has a number of other issues going on when she won't take it right now, but we're getting along at 77 and she's happy and she's going to talk about it later. The other key thing with Lp(a) is it's all genetic. It's passed down from generation to generation. It has a little bit of variable penetrance, but otherwise it is quite genetic. So you need to check their proband. You need to check their children. Okay? All right. How can you treat it? You can lower it with niacin. You can lower it with CTP. You can lower it with plasmapheresis. You don't actually lower it. What you do is lower the LDL, as I've stated. Okay? And then what you want to do with regards to the probands are you want to get them tested, and then you want to counsel them. So we actually got her daughter tested, and her daughter had an LDL of 149, a BMI of 22, an HDL of 55, and a Lp(a) of 250. Okay? And so the question is, what would I do with this lady? She's 22, so I'd wait right now, but I would pull the trigger very early in her for starting her on a statin. If it were a guy rather than a woman, I would start the statin now, or I'd try and twist her arm to get it started. With a woman, because of the issues with statins in pregnancy, I would wait. Okay? Once they have decided to become monogamous and for sure use birth control, etc., then I would start them on a statin, or when they're stopped having children, I would start them on a statin. For now, it was diet and exercise, although she was a pretty healthy-looking woman. Case 3. This is the last of the cases that we'll have here, although we have one more if we need to. And this you'll see very commonly now. And I'm using Indian as in South Asian Indian here, but anyone really from southern part of Asia, China, and all the way down, not including Australia, of course, is included, and American Indians, since they actually came from the same stock of individuals. This is a real population where you need to be very careful in looking at their LDLs multiple times and very careful in managing them aggressively, because a little bit of central fat in this population will change their LDLs dramatically. Okay? You can see this is a young gentleman. He's 35 when he comes to see me, and that was in 2010. And so 7 years before that, you can see the first time he measures his cholesterol, quite nice. The second time he measures it, quite bad. And the difference was he gained 10 pounds. Okay? 10 pounds of central fat in this guy because he started eating at the cafeteria all the time rather than eating at home. All right? Caused him to have a dramatic increase in his LDL. He had genetically problems with triglycerides and HDL, but his combined hyperlipidemia went crazy when he started eating cafeteria food. He exercised and started losing 10 pounds because he went to a different job, and boom, his LDL went right back down again. His triglycerides were actually under fairly good control then, but once again he had an elevated triglyceride on another fasting sample and then yet another one. And the question is when you see him in February, what would you do for this individual? Very low HDL, very high triglyceride, total cholesterol not so high. Okay? So one of the things I do in a patient like this to try and figure out their risk is something called subfractionization of their LDL. And what that is the following. Okay? LDL is like looking at hamburger that you're going to put in spaghetti. Okay? I know how much hamburger I'm going to put in. I don't know what the sauce is. Do I have spaghetti and meatballs or spaghetti and meat sauce? Spaghetti and meatballs, very few particles. Spaghetti and meat sauce, lots of particles. Lots of particles means huge risk for disease. Very few particles means low risk for disease. If you want to look at who to treat, that's one of the things I often do when I want to pull the trigger on a very young person. Okay? It's better than exposing them to 20 years of drug that they may not need. And low particle number correlates very nicely with not having disease. High particle number correlates fairly well with developing disease. And this guy really wanted to know, so this is what we did. His particle number was 1,609, which is less than I thought it was going to be. I thought it was actually going to be around 2,400. Okay? His small dense LDL, which is analogous to what kind of hamburger you're putting in. Top sirloin is a low small dense LDL, and very bad beef is a very high small dense LDL. This is not so good for you. Small dense LDL is very sticky. Okay? Almost all of his particles were very sticky particles. And that fit with his triglycerides being high and his HDL being low and him being Indian. Okay? That fits incredibly well. It's well known in the metabolic syndrome as well, those kinds of patients. This is what happens. It changes your LDL from big and fluffy to small and sticky. Okay? We got another the total cholesterol associated with this showed that his triglycerides were actually quite high, HDL quite low, and he had an estimated LDL of only around 100. So we actually put him on a fibrate. And when we put him on a fibrate, then this is what his numbers did. So his triglycerides came down quite nicely. Okay, his HDL stayed about the same. This is what you'd expect. And his LDL was 138. And then there are two options. And this is all guesswork, as there's no real evidence for what to do here. So I involved the patient, talked to him about what he wanted to do, whether he wanted to be aggressive or not be aggressive. If you're conservative, you can stop here because the triglyceride is pretty close. You could add fish oil to drive the triglyceride down a little bit more if you wanted to, but less than 200 is your goal. Okay, 138 is a reasonable number. If you want to be aggressive, I'd get his LDL well below 100. Okay, and add a statin or add niacin. This guy didn't want to deal with the flushing, so he chose the statin. And what we did is dose him with the statin that would get his LDL down to around 70. Okay, and this is where you have to use personalized medicine in that you personally talk to the patient and try and get them involved in what they want to do with their care, and you tell them kind of what your thoughts are on what the evidence is going to be when we do the right trial.
I was going to say, you let them know we don't have the evidence yet.
Absolutely. But this is the best we can do looking forward.
Here's what,
One more case.
Yeah, so we this is a tough one. I like this case. The older woman, meaning more like your age or...
Yeah, our age.
Or my age, okay.
Yes.
Who has an elevated LDL, so it's in the 160, 170 range, but also has an HDL that's pretty good, 75, 80. Right. What do we do with that one?
Right. So this is a big proportion of the population, and the key question is what do you do with someone who comes in, LDL's higher than you'd like to see, around 160, 170, getting older, which is a huge risk for developing coronary artery disease, but their HDL is very high, just perimenopausal or just past menopause now, so their risk starts to go up with regards to them being a woman, and what do you do? I think one of the biggest keys is you got to know what their triglyceride is. Again, just like the Indians, okay, individuals who have a high triglyceride in those kinds of numbers are going to be much more atherogenic. Individuals with a low triglyceride in those kinds of numbers are going to be much less atherogenic. In other words, their LDL is either going to stick or not stick, okay? And if it's 160 and doesn't stick, who cares? If it's 160 and sticks badly, you care a lot. You can do non-invasive testing and try and evaluate their atherosclerotic burden. The options for non-invasive testing are carotid ultrasound or some sort of imaging scan of the coronary arteries, the most common one being electron beam imaging. Okay. Now, the electron beam imaging isn't electron beam, it's X-ray beam. Okay. And the biggest problem with doing that is you're looking at exposing a woman who's probably going to get other radiation exposures during her life to radiation in a very confined beam right through the breast. Okay, and a lot of people don't like that. The carotid imaging is very reasonable. It's ultrasound. We all know the safety there. What they're looking for in carotid imaging is the intimal thickness. If the intima is thick, they have disease. If the intima is thin, they don't. If they don't have disease, there's no reason to treat that number. If they do have disease, you have a basis for going ahead to treat. And along with that, I would also get a CRP. Okay, and this is exactly the kind of person that fits into the Jupiter trial. Okay, in Jupiter, they all had LDLs less than 130, but it's going to apply for people with a higher LDL. They had LDLs less than 130 because ethically that's the only patient population they could put in. Expanding on what that showed is if you have a high CRP and you have a high LDL, bad combination, we know that. So I would go ahead and treat. This individual actually had a CRP of 1, which is what the goal is, Okay, so they didn't fit into that trial either. So then you really need to look at either imaging or giving them a pat on the back and saying,
Probably
things look
okay.
pretty good. You also can use that advanced lipid testing that I talked about, the same one, as another surrogate, looking again at whether or not they're very atherogenic or not. Triglycerides pretty much give you a good idea of that. If they're high, they're going to be atherogenic. If they're low, they're not. If they're in between, then the lipid panel is sometimes good, the NMR panel.
All right. Terrific.
Thank you very much.
Thanks, Mike. That was a great talk.